Good afternoon, everyone. My name is Denise Mananis. I am the Senior Director for External Affairs for St. John's Riverside Hospital, and I'd like to welcome you all today to our presentation on cracking COVID-19's impact on the heart. Before we begin, I would like to thank our IT staff, Mike Maltalal and Jason Latour, for always helping us get through all the technological challenges we have, and my team, Nancy Anabi, our community liaison, Candace Cousin-Hopkins, and Olivia Hunter, who are our associate directors of marketing, who make all of this possible and beautiful, by the way. So before we start the program and introduce our speaker, I'd like to also introduce our community partners. We have Sally Pinto from the Yonkers Neighborhood Naturally Occurring Retirement Community. That is under the umbrella of the Yonkers Office for the Aging and the Westchester Jewish Community Services. They provide programs, activities, services, including nurse and resource specialists to seniors 60 plus living in Northeast Yonkers. And Z. Baird, who is from our Yonkers Public Library, which has 3 locations, the Riverfront, the Will, and the Crestwood Libraries. You can visit their website, which is www.ypl.org, 4 hours of service, the programs that are free, downloadable books, streaming movies, and more. So with that, I would like to introduce our speaker, Dr. Stephen Francescone. He is a graduate of NYU School of Medicine, where he was elected to the AOA Honor Society. He completed his internship and residency in internal medicine at New York Presbyterian Cornell, where he served as an assistant chief resident. After completion of his internal medicine training, he went on to fellowship in cardiovascular disease at the Mount Sinai Hospital, where he also served as chief fellow. He is board certified in internal medicine, cardiovascular disease, echocardiography, and nuclear cardiology, and he is currently chief of cardiology at St. John's Riverside Hospital. He is a Yonkers native and has practiced general cardiology here for at least the last 10 years. He is a member of the Mount Sinai Doctors Riverside Medical Group, and his clinical focus is on preventive cardiology, cardiovascular risk reduction, and optimization of established cardiovascular disease. So with that lengthy introduction, gives me great pleasure to introduce Dr. Stephen Francescone. Thank you.
Thank you, Denise, for that very nice introduction, and thank you to St. John's for the invite. I am very happy to be here today with all of you to discuss this very important topic, which has impacted our lives for the last year. Although it is a challenge to get into this in great detail, I hope to give you all a nice general summary of all the important aspects of COVID and cardiac manifestations over the next 20 minutes or so. So, as we all know, coronavirus is caused by SARS-CoV-2, which stands for the Severe Acute Respiratory Syndrome Coronavirus 2. Over the last year, it has significantly impacted all of our lives, socially and in many respects, as well as the practice of medicine and healthcare. Although we have always known that there are many viruses out there that can impact the heart, particularly Coxsackie virus, adenovirus, parvovirus, and others, we now know that COVID-19 can impact the heart significantly. The knowledge of how it does so is evolving, but over the course of the last 12 months, data has emerged, and we have made some significant clinical observations which I hope to share with you today. I know the audience is a mixed audience of healthcare providers and others, so I hope to achieve some detail in terms of clinical detail, also balancing it with a general overview. Many questions do remain in this area, and investigations are in progress. So let's go over all the areas we will talk about today. I'd like to start by talking about how COVID creates heart muscle damage. And this is something that we saw early on from the beginning of the pandemic in hospitalized patients. Something we saw early was that there was laboratory evidence of myocardial or muscle cell injury, heart muscle cell injury in patients who are critically ill in the hospital. Next, I'll talk about the importance of pre-existing conditions and how these conditions place patients at an increased risk of severe COVID and other clinical implications of that. We'll then move on to specifically talk about how the virus can affect the heart from what I'd like to describe as the outside to the inside, affecting all three tissue layers of the heart. We'll then go on to discuss some clotting issues, which is a very hot topic. We'll talk about why it happens or the theories behind why clotting is more prevalent. And also, I'll give you some basics on our approach to preventing it. We'll then move on and talk about some common cardiac medications, medications that are on everyone's mind, aspirin and some other common blood pressure medications known as the ACE inhibitors or the ARBs. Lastly, I'll finish up by touching on something that is emerging called the post-COVID syndrome. It is an area of ongoing research and has become a clinical focus now as we move forward in the pandemic. So getting right to the heart of the matter, I'd like to first talk about evidence of heart cell damage. As I mentioned before, we noticed early on that we were seeing elevated cardiac enzymes in the blood. We know that about 7 to 36% of hospitalized patients demonstrate evidence of heart muscle cell damage or strain. And we see this by way of an elevation in cardiac troponin levels. Troponin levels are heart muscle enzymes that are measurable in the bloodstream. We usually see this in the more severe complicated cases with critical courses. And what we now know from studies done in Wuhan and in Milan is that the presence of these enzymes can correlate with a higher rate of mortality. So it does carry a prognostic significance. I think it's important to understand how any virus can impact the body. Like any systemic infection, COVID increases physiologic demands. What happens is that there's a heightened immune response with release of cytokines, which are chemicals that the body produces to help fight infection. This creates fever, which creates an increased heart rate, which can lead to a drop in blood pressure and often drops in oxygen levels. As you can imagine, the result of all of this is a stress on the heart. The heart has to beat faster, it has to pump harder, and this can provoke damage, especially in patients who may have underlying heart disease. You can imagine a patient who may have already developed atherosclerotic plaque over the years, may have chronically obstructed arteries, and when the heart has to respond in this way, beat faster, beat harder, a strain is placed on the heart. Let's talk about pre-existing heart disease, something that's extremely important in understanding how we take care of patients. We now have substantial evidence of the association between pre-existing cardiovascular disease and the risk and severity of COVID infection. Patients with underlying hypertension, coronary artery disease, and congestive heart failure have been found to be more susceptible to more severe illness. Several theories have emerged as to why this might be the case. Patients who have these underlying conditions may have impaired cardiac and pulmonary reserve. They may have an impaired immune system, and they may be more vulnerable to the blood vessel damage that occurs from the inflammation that the virus can cause. Congestive heart failure is particularly concerning, and I'll touch upon that in the next slide. Because of this, vaccinations are encouraged in these subgroups, and we have prioritized these subgroups. Let's focus on heart failure for a second to try to understand how important these underlying conditions are. A study of about 6,000 patients with COVID in New York found that having a history of congestive heart failure was associated with a longer length of stay, an increased risk of requiring mechanical ventilation, as well as mortality. These were all significant findings. So as a result of this, we strongly advise adherence to the CDC guidelines in terms of social distancing, hand washing, and vaccination for all of our patients who may have these conditions and others that have been outlined. Okay, so let's switch gears now and talk more specifically about how the heart itself is affected. As I mentioned at the beginning, COVID can infect the heart from the outside to the inside, all three layers, starting with the pericardium. The pericardium is the thin outer layer that surrounds or cushions the heart. You can think of it as a very thin layer of cellophane surrounding the heart and cushioning it. Many viruses are known to potentially cause inflammation of the pericardium, including Coxsackie and CMV. What happens is patients can develop inflammation around the lining of the heart. They may develop symptoms such as sharp and positional chest pain. Sometimes there's fluid that can build up around the heart from the inflammation. This has been rarely described with COVID, only a few case reports, but it is possible. And this is a condition that almost always resolves with non-steroidal anti-inflammatory drugs such as ibuprofen and aspirin. I want to spend a good amount of time talking about how COVID affects the heart muscle cells themselves, or the myocardium. These are the cells that control the force of contraction and also the conduction of electrical activity in the heart. We know that around 10 to 40% of patients demonstrate either right-sided or left-sided cardiac dysfunction on ultrasound. We see this most commonly in the patients who have elevated cardiac enzymes, as I had described earlier. A condition called myocarditis is commonly suspected clinically. This is a condition where we see elevation of cardiac enzymes in the blood, cardiac arrhythmias, and heart muscle dysfunction or weakness. The idea here is that the virus can kind of get inside the muscle cells, disrupt the architecture of the heart, leading to weakness, leading to abnormal rhythms, and leading to strain, fibrosis, and dysfunction. We also see other entities. There is an entity called stress cardiomyopathy, where the heart becomes diffusely weakened and sometimes enlarged. The good news is that this is usually a temporary situation, and recovery is possible with medications. We have seen cases of isolated right-sided weakness of the heart due to the right side of the heart being overworked or strained, secondary to the lung disease that occurs with COVID, or due to the blood clots that can develop. Sometimes the degree of muscle dysfunction is so severe that it can lead to circulatory collapse, cardiogenic shock, and severe congestive heart failure, where we need to use medications to support the blood pressure, and sometimes even extreme measures such as ECMO, extracorporeal membrane oxygenation, which is a machine that can basically circulate and oxygenate the heart, taking place of the heart and the lungs. And finally, in discussing the myocardial or the muscle involvement, I'd just like to mention that there have been some studies done using cardiac MRI in post-COVID patients that have confirmed the presence of fibrosis, infiltration of the virus into the muscle cells of the heart, and injury. So we know we definitely know that this is an entity that happens. I'd like to now move on and discuss COVID and blood clotting, a very popular topic that you may have read about in the news and seen on television, different cases of patients developing significant clots. There have been cases of heart attack, blood clots in the lungs, blood clots in the veins of the lower extremities, strokes, as well as clotting in the arteries of the legs. Several possible causes have been discussed, including small vessel inflammation, damage of the larger vessels, as well as rupture of pre-existing plaques. There are also changes or alterations in the levels of blood proteins, such as fibrinogen and factor VIII, which control clotting. And this can lead to a disturbance in the clotting and cause an increase in clotting in the arteries and the veins. Overall, studies have shown benefits of using blood thinners in appropriate patients in prolonging their survival and reducing their mortality. I want to briefly talk about the clinical approach to preventing clotting, especially for the healthcare providers who may be on this webinar. So this slide is taken from the American Society of Hematology website and recommendations, which was updated last month. The American Society of Hematology supports the use of low dose or prophylactic doses of low molecular weight heparin as well as unfractionated heparin in all hospitalized patients, both ICU and non-ICU. Their guidelines basically say that in general, using higher doses of blood thinners or full dose blood thinners, the risks outweigh the benefits. However, they go on to say that clinical judgment may justify the use of higher doses or full doses to prevent clotting in patients who are considered to be at high risk for clotting and at low risk for bleeding. So this is a very sort of controversial area, and there are different local algorithms used in different institutions that have been developed based upon using different blood markers such as D-dimer and other markers of disease severity and inflammation. But I think everyone would agree that all patients require some form of prophylaxis, and the American Society of Hematology is currently recommending the use of prophylactic or low doses. There are ongoing trials on this matter investigating the optimal doses. Moving towards the end of our discussion now, I want to touch on common cardiovascular drugs, some common medications that we all take that may be on everybody's mind. So first we'll talk about aspirin. There have been some small studies showing a neutral effect of aspirin, but I think one study is worth mentioning here, and this was a study in October out of the University of Maryland. It was a retrospective study looking at 400 patients, average age 55, who had been hospitalized with COVID. About a quarter of them had been on low-dose aspirin prior to admission, or were started on it shortly after the admission. And the results of this retrospective study were very positive. The aspirin group had 43% likelihood to require the ICU, 44% were less likely to require a ventilator, and 47% less likely to die. And there was no increased bleed risk noted in this study. There was control for age, gender, and presence of other risk factors. Now, this is a study that is limited because it's retrospective. It is not a large randomized controlled trial, but still, I think the results are difficult to ignore. The theory behind why patients may have done better is that the use of aspirin may have reduced small blood clots in the blood vessels supplying the organs and preserve function of these organs. So I think the use of aspirin merits strong consideration in selected patients, both in the outpatient and in the inpatient setting. We should mention COVID and the use of some common blood pressure medications in the class of ACE and ARBs, angiotensin converting enzyme inhibitors and angiotensin receptor blockers. So common names for these drugs are losartan, olmesartan, ramipril, enalapril, and there are others in that family. Initial reports last spring were advising against the use of these drugs because there were concerns that they may allow the virus to more easily enter the cells, making patients more susceptible to COVID. And this has to do with a very sort of complex biochemical mechanism. But since then, there have been 4 studies with over 13,000 patients in several countries, which have shown no increase in the susceptibility to COVID. And so the ACC and the AHA have issued statements that these important medications should be continued. And actually, the risk of discontinuing them is greater. I'd like to close with a final slide on the post-COVID syndrome. So anywhere from 2 to 25% of patients who have had COVID become so-called long haulers, where they have persistent symptoms weeks to even months after being diagnosed. These lingering symptoms can be variable, but they can include generalized fatigue, persistent shortness of breath, persistent cough, ongoing chest pain complaints, muscle and joint pains, headaches and migraines, elevations in heart rate, particularly the sensation of inappropriately elevated heart rates for the degree of activity. So many patients will complain that they feel their heart rate very elevated, that they notice their heart beating rapidly and forcefully, even when they're not doing anything or doing minimal activity. Memory has been affected. There have been reports of hair loss, anxiety, even depression. We're still trying to figure out exactly what the mechanism behind these symptoms may be, but there have been several possible mechanisms discussed. One is this dysautonomia, which is the medical word for an impairment in the nerve output to the blood vessels. Basically, the nervous system gets disrupted and fails to communicate properly with the blood vessels, disrupting blood flow to the heart and the brain, resulting in the heart not really knowing how to respond properly, so that it's beating faster when it shouldn't, blood pressure is changing when it shouldn't, blood vessels in the brain are opening when they should be normal sized, and this can lead to the sensation of palpitations, migraine headaches as well. Other theories have invoked ongoing organ inflammation, particularly in the lungs. Other theories include autoimmune reactions and blood clots forming in different blood vessels. So the mechanisms are varied. We don't fully understand it, but we know it's happening. There is research ongoing in this area. For now, I think the consensus is that patients who may be experiencing any of these symptoms need to be monitored closely by their doctors and by their specialists. Many centers, including St. John's here locally, Mount Sinai, and other tertiary centers, have created specialized programs and clinics to follow patients going through this post-COVID syndrome. So with that, I'd like to sort of wrap up.
I do have questions, Doctor, from the audience. So if you have a few more minutes, we can go through some of those questions.
Yes.
Okay. So the first question, Does the amount of days that you are COVID positive directly correlate with an increased chance for an MI, which is a heart attack, I believe, a pulmonary embolism, a DVT, or other limb ischemia?
I think that's a great question. I don't think necessarily the number of days that you test positive is correlated, but the number of days that you are ill, in the hospital, immobile, does. Because we do know that prolonged immobility, prolonged inflammation does correlate with those entities.
Okay, thank you. Another question, I am otherwise healthy. Will contracting COVID-19 put me at increased risk of having heart disease later on?
Great question. I think the honest answer is we don't know. Probably not, but it's an area that we're still following very closely because we do have patients who have been otherwise healthy who are experiencing some of the symptoms I discussed in the post-COVID syndrome. And we're gathering data and we're following patients longitudinally to be able to answer that question.
Got it. Are there any side effects that from the vaccine that correlate to heart disease?
Not to my knowledge. There's no specific side effects from the vaccine that would particularly worsen heart disease. I think the side effects that we've been hearing about are mild aches, some mild myalgias, fever, generally resolve within a day or two. They've been responsive to Tylenol and non-steroidals. I think it's actually very important that patients with the underlying heart diseases that we discussed get vaccinated because they are at increased risk of more severe COVID potentially.
Okay, another question has to do with a little bit of you addressed with the aspirin or the use of aspirin, but are there any other medications or supplements that either protect me from COVID-19 or from COVID heart complications specifically?
Mm-hmm. A common question. I'm not aware of any studies, large randomized controlled trials that have actually proven any benefits. I think vitamin C is helpful for the immune system in general. I think that zinc has been shown in some small studies to potentially inhibit viral replication, and when taken properly under the guidance of your doctor, it is generally safe. But there are no supplements that have been proven, to sort of prevent COVID or prevent severe COVID.
Okay. Here's another question that we have. I'm hearing that hospitals are strained right now. Should I still call 911 if I think I may be having symptoms of a stroke or heart attack?
Yes, absolutely. First of all, I think that the numbers of COVID are going down. And secondly, if you don't call 911, you're potentially missing an opportunity to receive some very important life-saving therapies, particularly for stroke and heart attack, because those conditions are very time sensitive, and getting to medical care on time is important because you may be eligible for cardiac catheterization and stenting, and for stroke, you may be eligible for something called TPA, which is a medicine that can be infused to dissolve the blood clot that's happening in the brain, and those treatments are very time sensitive. So if you delay, you may then come to medical attention when you're outside of that window, and by that time, significant damage may be done.
Is there a preferable vaccine? Oh, by the way, I just wanted to say in regard to that answer, St. John's just received its gold stroke certification and was also just certified in its first Joint Commission survey for stroke care. and we are a stroke center in our emergency department, so our audience should know that. Back to this question, which is if I have had COVID, is there a difference in the vaccine? Which ones I should get? Moderna, Pfizer, Johnson & Johnson?
Mm-hmm. You know, we've seen that the Pfizer and the Moderna have reported immunity between 95 and 98%. The Johnson & Johnson, which was recently approved, has the advantage of being a single shot, although the immunity levels reported with that seem to be slightly below, around 70%. So, you know, I think the important thing is to get a vaccine. Whatever vaccine you can get, moving towards getting the whole population vaccinated. Herd immunity, I think, is the only way that we can get out of this.
Thank you. And the last question I have is for from someone who asked if they do have some cardiovascular issues such as hypertension or plaque buildup, are there, without becoming panic stricken over every little thing, are there some specific signals or symptoms that they should be aware of or looking for if they notice something?
Is that specific to having COVID or just in general?
I think in general, but I think in relation to having COVID is the way I think most people before COVID felt very like, well, if my heart rate goes up, I should call the doctor, or if I get dizzy, or if my blood pressure goes up, that kind of thing. I think they recognize that. But is there anything else that, particularly post-COVID, if someone's had COVID,
right?
Is there something different that they would be looking for?
Yeah, so focusing on post-COVID, I think that if you're experiencing any of the classic symptoms of a heart attack, chest pain, chest pressure, jaw pain, nausea, vomiting, sweating, feeling different when you're exerting yourself, feeling lightheaded with exertion, feeling unusually tired with exertion. Those are sort of the classic symptoms of heart disease, and those should not be ignored. If you've had COVID and you're not having those sort of marked classic symptoms, but you're still not feeling quite right, maybe still short of breath, still not able to tolerate exertion quite the same, lightheaded, maybe feeling your heart rate is elevated, maybe even feeling chest pain. These are all common symptoms that we're seeing in patients post-COVID, even patients who had no underlying conditions. And so I think if you're experiencing any of those things, it's important to come and see your doctor and get checked out for some of the residual inflammation that can happen in the heart and the lungs.
Thank you very much, Doctor. That was our last question. But I did want to point out for our audience that as we post some information for our audience, we have established a post-COVID care program, which is located at our Boyce Thompson Pavilion. And, specifically for those patients who, just as you said, are experiencing some of those things, this is an opportunity to help people in the community who may need referral to some other specialists, such as yourself, to really kind of get to the bottom of what they're experiencing. And so there's our number, 786-0013. Those are the appointment times. If you would like to get more information from today's program, please feel free to email us at info@riversidehealth.org, info@riversidehealth.org. And Doctor, I'd like to just thank you once again for being with us, and we really appreciate your time and your education.
Thank you. It was my pleasure.
Thank you. Bye, everybody.
Bye-bye.